And I'm going to go ahead and introduce our speaker. Today we have our speaker, Miss Julia Wood. Julia is an occupational therapist specializing in assessment and treatment of people with Parkinson's disease and related dementias. Julia is currently the Director of Professional and Community Education at the Lewy Body Dementia Association. Julia has served as faculty for the Parkinson's Foundation Team Training for Parkinson's program since 2016, certification and training faculty for the LSVT BIG program since 2018, and served in the Parkinson's Foundation Rehabilitation Task Force in 2021. She co-authored the first American Occupational Therapy Association practice guidelines for adults with Parkinson's disease in 2022, and serves on the Comprehensive Care Subcommittee for the World Parkinson's Congress in Barcelona, Spain in 2023. It's really an honor to have Julia here with us. She's a wealth of knowledge. So thank you so much, Julia, and I'll let you take it from here.
All right. Thank you so much, Ellen, for the, the amazing introduction and for having me today. We've been struggling. I'm in the Philadelphia area. We've had those horrible air quality conditions that you've heard about. It's gotten better, but if you hear, I may get a little froggy from time to time, so I apologize. So I'm going to go ahead and share my screen to get started with the presentation today. And it helps when we pick the right window. Here we go. All right. So let's talk about Lewy, shall we? Right. So as Ellen mentioned, my role is the Director of Professional and Community Education. So as you can imagine, this is just my jam. This is what I love, is really helping to empower families, clinicians, healthcare providers, friends, neighbors, communities, to understand more what Lewy body dementia is. And so I'm going to kind of give you an introduction and overview today, and then I'm going to hit some points, hopefully, for those healthcare providers that may be in attendance as well. So basically, I'm going to define what LBD is today and explain how it's different from Alzheimer's, because for so many people in our society, Alzheimer's disease equals dementia. I think all of the organizations, we're really working to try to refine that and help people have a better understanding, but it's going to be a slow process. We're going to look at how the symptom presentation is very different with LBD from Alzheimer's disease. And then I really want you to be aware at the end of this presentation of 3 possible multidisciplinary team members or different types of clinicians that may be as referral sources for my social workers out there, or for some of the healthcare providers, or maybe people to talk to your doctor about in helping you manage your Lewy body dementia. And so full transparency in that, she read my bio. I was part of an interdisciplinary care team at the University of Pennsylvania for almost 10 years, and this was my area of specialty. And so there's a lot rehab professionals can do to help people living with Lewy, and we find that those resources often are not utilized as much as they should be, or maybe people aren't aware of them. Sometimes clinicians aren't even aware of how to best address Lewy body dementia. So just want to start with the umbrella that I'm sure that you guys have seen a lot, where we talk about these different types of dementia. And you'll notice that even though you may not have heard of Lewy body dementia, or maybe a lot of you don't really know about it, it's a large chunk of our dementia cases. So you'll notice there it's 10 to 25%. And this slide was done a little bit ago. My understanding is it's actually grown. I think that it may have even surpassed vascular dementia as the second most common. But you'll notice next to Alzheimer's, it is the second most common type of progressive dementia. So, we do know that there are a lot of people who are misdiagnosed, and we'll talk about that later too, but it's definitely not rare, is my point with this slide. So some things that you might know. It's the most often misdiagnosed form of dementia, and we're going to talk about that a little bit later. It's estimated that there's 1.4 million people living in the United States with Lewy body dementia, and these are mostly adults over the age of 50. But we do sometimes see people younger. We have a lovely woman in our community who is a volunteer, and she was diagnosed in her mid-40s. So it's not unheard of. As I mentioned before, it's the second most common cause of progressive dementia after Alzheimer's. And we'll get into this a little bit more. Some research studies indicate that it's actually the most expensive form of dementia in healthcare cost. So how is this defined? Well, as I mentioned, it's a progressive brain disorder, so it's going to advance and get worse over time. And it features these abnormal protein deposits in the nerve cells of the brain that are called Lewy bodies. And these clumped proteins, if you can think about like the neurons are trying to send their signal and communicate, if you think of those almost like a highway, right? It's like we've got a big traffic jam. That big Lewy body kind of makes a block to where signaling then can't go through. And it can affect a lot of different areas of the brain. It's named after the neurologist who actually was German, so it technically would be Lewy, but we say Lewy. And the difference you'll notice below under our umbrella in these two different types of Lewy body dementia is in what we call the 1-year rule. So it gets a little confusing here. I apologize. We get into a little bit of alphabet soup. So Lewy body dementia actually includes two types of dementia. Parkinson's disease. Your screen. So how do we tell these apart? The difference is in this 1-year rule. So in the case of Parkinson's disease dementia, someone already has had Parkinson's for some time, right? And now they've started to develop dementia symptoms. We know over time that this can happen to approximately 50 to 80% of people living with Parkinson's disease. So in the case of dementia with Lewy bodies, the development of dementia or the cognitive changes happens at the same time or before the movement changes that we typically think of with Parkinson's. So one of our experts likes to call it the chicken or the egg under the umbrella. So if you think of it, it's what came first. She said if the Parkinson's disease comes first, those changes to stiffness, slowness, movement, then they develop dementia, that's Parkinson's disease dementia. If the dementia comes first, that's dementia with Lewy bodies. So you can think of it as which comes first. Good thing for you all to know is this is still in debate and argument even to this day as far as the naming of these conditions, the staging of them. So I have a feeling there'll be some shifts and changes to this possibly in the future. So how is dementia with Lewy bodies different from Parkinson's? Well, as I mentioned, the big thing to know is Parkinson's is always going to affect movement. So there may be some changes for people with PD, even in the beginning, even early on at diagnosis, but those are mild changes, often even just subjective, where the person feels like their thinking is different, but they don't necessarily show a deficit if you do some type of a test. Later on, as I mentioned, those individuals may go on to develop dementia. In dementia with Lewy bodies, it always affects cognition. And they're going to have one to several other symptoms that we'll talk about more. But some people don't show any obvious Parkinsonism or changes to their movement in early stages. And we even have some people in our community that never really show, the things that you think about with Parkinson's: tremor, stiffness, that shuffling gait. Some of them never really have those changes to their movement patterns. Here's the big one. So how is it different from Alzheimer's disease, right? Which is what we typically think of. So I want you to notice, I'm going to kind of walk you through this bar graph a little bit here. On the left side of your screen, you'll notice the top graph is Alzheimer's disease, right? The bottom bar graph is dementia with Lewy bodies. If you look at that dark purple bar that I'm kind of hovering my cursor over here, where it says global on both, that's the dementia rating scale, or the DRS. Notice that both of them are pretty similar. So that's like a overall rating with their dementia, overall like a global look at cognition, right? But that's where the similarities stop. So if you go next to that in those red bars, notice memory with Alzheimer's at the top, how low those scores are, how low those bars are, right? Because Alzheimer's is more of an amnestic condition where people, the impact is mostly in memory. We think of Alzheimer's, people not remembering their children, people not remembering their loved ones or events in their life. So that's a very typical presentation with Alzheimer's disease. Now compare that to the red bars on the bottom where it says memory for Lewy body dementia with Lewy bodies. Look how much higher that is. So our people with dementia with Lewy bodies don't typically have a lot of profound memory changes. Now, they may think they do, and we'll talk about that a little bit more. It typically is kind of confused with issues with attention. So you'll notice next to it now in the green bars there, we've got language, right? And so you notice that with Alzheimer's, they're pretty much the opposite too. The two are lower on the sides, the one's bigger in the middle, and it's almost the opposite presentation with dementia with Lewy bodies. So language is much more impacted with Alzheimer's disease than it is with dementia with Lewy bodies. Now, here's where it really shifts. Look next to that in the yellow, that attention and executive function. And executive function is where you're trying to follow complex steps, maybe following a recipe or trying to execute something that you have to do a sequence, like getting clothing out, getting the clothing set up, putting it on. That's where we start to see the big change. Notice how much higher those scores are for people with Alzheimer's compared to at the bottom for dementia with Lewy bodies. Next to that in the blue is visuospatial function. So that's your brain's ability to map space. So things like you set a coffee cup down on the table, knowing that it's not right on the edge and going to fall off. Also directional, like mapping in your home, mapping in your community to where you're going to go. Notice how much higher that is in Alzheimer's disease. They don't really have impairments in that typically, compared to on the bottom, those same, tests, but completed by someone with dementia with Lewy bodies and how low those scores are. So, if you take nothing away from this today, I hope that you understand that Alzheimer's definitely does not equal dementia, and dementia with Lewy bodies is practically the opposite presentation of what we see with Alzheimer's disease. So very, very different types of dementia. All right, another place that they really digress is fall risk. And I'm not going to spend a lot of time on this, but I just want you to be aware that, the onset of recurrent falls is much shorter in dementia with Lewy body than even for people with Parkinson's disease. Because I know a lot of times clinicians out there, maybe therapists, maybe you're used to seeing people with Parkinson's, your people with dementia with Lewy bodies are potentially going to have a lot more falls and much quicker. There's also a far greater fall risk and a shorter latency period from diagnosis to when the person starts to have these repeated falls in dementia with Lewy body than Alzheimer's disease. So very important that we get our people with dementia with Lewy bodies in with occupational therapy, physical therapy. We start to work on that falls prevention and safety very early on. Those with Parkinson's disease dementia and dementia with Lewy bodies have increased fall risk and poorer scores on their gait and balance measures than those with Alzheimer's. So we really want to make sure we're treating the whole person here and thinking of the safety. We had someone in our community recently that was severely injured from a fall, and this is very common. And more severe Parkinsonism, which are those movement changes, is associated with increased falls. So the more that you see the shuffling gait, the tremor, the shakiness, the stiffness, those are the people who are probably going to be more prone to falls. And then, our physical therapy colleagues can really look at this because that's who tests for gait and balance issues a lot, right? And those are associated with increasing falls risk in dementia with Lewy bodies. So we want to, at my clinic anyway, we followed up on people about every 3 to 6 months because most of your gait and balance measures that a PT is going to do are only good for 6 months. That's how long that window is that they're still accurate and predictive of a falls risk. So not only do you want to see PT and OT, but you're going to need to see them fairly frequently to keep an eye on this and keep you safe at home. And this also, unfortunately, is linked with nursing home admission. So when we look at people with Alzheimer's disease and dementia with Lewy bodies, our DLB people have the shortest time to nursing home admission by almost 2 years. The duration of symptoms prior to the diagnosis with dementia with Lewy bodies and the use of antipsychotic meds is associated with this increased rate of nursing home admission. So we'll talk about that more. Once they're admitted to a nursing home, our individuals with dementia with Lewy body have increased mortality rates compared to our people with Alzheimer's disease. And so we want to try to keep people home and safe as long as possible because we've still got a lot of issues that we're dealing with as far as proper care and management of these folks once they enter a nursing home. And this last one's really important. We're going to talk about the medication sensitivities later on, and these can be deadly. So some of the medications that you would typically give someone for Alzheimer's disease for behavior, like haloperidol or Haldol, can literally be deadly for someone with Parkinson's disease dementia or dementia with Lewy bodies. And a lot of people don't know that. So as you can imagine, when we wrap all this up, it can be a very costly condition as well. So individuals with Lewy body have more severe functional impairments early on than individuals with Alzheimer's disease. So a lot more need for care. LBD is also associated with a higher mean annual direct care cost than all of the other dementias, if you look there. The cost differences are driven a lot by hospitalization, and that's something we're working on right now at LBDA, is really trying to get some safer hospitalization protocols in. But as you can imagine, that can be very difficult. It kind of takes everyone working on it because there's so many hospitals out there. And then LBD has higher annual cost than Alzheimer's disease, and this is related to falls, urinary symptoms, depression, dehydration, anxiety, delirium and psychosis, orthostasis, and sleep disorders. And we're going to be going through all of those different symptom buckets. And I think at the end, you'll understand how completely complex this condition is. So what does it take to get diagnosed with dementia with Lewy bodies? What does it actually look like, this symptom presentation? Well, there must be enough cognitive decline that it's impairing daily activities. That's really what dementia is. It's just a clinical term. It's not any type of a disease for sure. And then they have to have two of the following features along with that cognitive decline. So I mentioned Parkinsonism, which is that slowness of movement, that stiffness with their movement, the shakiness or tremor. They will, visual hallucinations are also very common. These are usually well-formed and complex of people or furry little animals, but sometimes they can really vary in the presentation. Everyone's a little unique with that. REM behavior sleep disorder, we now know for a lot of types of dementia is a precursor many years prior. So someone who's been acting out their dreams, even violently. And this often happens a long time before any other symptoms. And my husband sometimes will say, I was laughing in my sleep or talking in my sleep. I'm like, yes, but was I acting out my dreams? Because I know what that means is coming down the pike if that starts to happen. With cognitive fluctuations, this is a real hallmark and a very distinctive feature of dementia with Lewy bodies. And this is a change in the level of alertness, attention, or arousal. So the person might seem 1 minute like they're fine and really clear, and you're talking with them, they're doing great. And then the next minute they seem really zoned out. This can happen day to day, hour to hour, minute to minute, and it can be really, really frustrating. But one thing I want you to remember from this, they are not faking it. I don't know everyone's loved one. I don't know maybe how ornery they might be or really like to play around or aggravate you. But when you see that cognition, that kind of glaze over and they zone out, they're not faking it. Even if they were fine just a couple of minutes ago, this is a very hallmark presentation. And it's important to note that all of these symptoms can also occur in Parkinson's disease. So you can imagine how difficult this can be to diagnose. We're going to talk more about that right now. So when it comes to receiving an actual diagnosis of Lewy body dementia, this study by one of our scientific advisors, they found that almost 70% had to see at least 3 physicians to get an accurate diagnosis. And 50% of those who were diagnosed, it took 12 to 18 months, so a year to a year and a half to receive an accurate diagnosis. It's important to note that 62% of the physicians who diagnosed these individuals were neurologists, and less than 10% of people were diagnosed by primary care providers. So it's not always enough to just go see your primary care doctor. And if you're seeing your primary care doctor and they keep telling you that you have Alzheimer's or that you have Parkinson's, might be a good idea to get a referral or to go see a neurologist and really try to get a clear diagnosis. It's important to note too that 78% of people, and I definitely saw this in my practice, had been diagnosed with something else first. Typically, that's Parkinson's disease or Alzheimer's disease. So, a lot of presentations I give, people will be like, whoa, some light bulbs are going off as I'm talking, and their loved one's been diagnosed with one of these other conditions, and it may be time to go and try to check and make sure you have an accurate diagnosis. So these are the clinical features. I think I kind of mentioned a lot of these earlier. You'll notice so many areas that can really be difficult for a family to cope with. These cognitive challenges, those fluctuations that I talked about can be very, very stressful. Sleep can be impacted. We'll talk more about that. But when we sleep with someone, if they're not sleeping well, typically we're not sleeping well. So this can impact our care partners as well. Autonomic features we'll talk about, and that's related to things that your body automatically controls, like your blood pressure, your urination. There can be a lot of sensory issues, and vision is one of these for Lewy. Taste, smell also can be impacted. Motor symptoms we'll talk about, those are related to movement. And then when we talk about neuropsychiatric features, we're talking about things that impact mood, like anxiety or depression, and also things that impact behavior. So I mentioned these cognitive fluctuations earlier. Like I said, you're going to see this kind of, roller coaster almost of levels of concentration and attention. When they have a moment of clarity, we sometimes call that showtime. And as you can imagine, a lot of times those might happen when you're at the doctor. So here you come in and you've got all these complaints, and then your loved one like turns it on and looks great. And you're like, wait a minute, that's not what we've been dealing with at home. That's completely normal and to be expected. They can have unexplained episodes of confusion, and these can be scary for the individual, if they're really confused about what's going on. As I mentioned, you'll see those periods where they may zone out, and excessive daytime sleepiness also kind of falls under sleep symptoms, but sometimes we'll link in with these cognitive fluctuations, but that's also very common in Lewy body dementia. So then looking at these different domains, when we're talking about attention, that's where our concentration is challenged. So after you're paying attention to me for a while, you might feel like your mind's kind of wandering, or maybe there's little sounds or things in your environment that may be impacting you. We know too that people with Lewy often become less aware of their surroundings. And so they may, tripping hazards can be a problem. Safety can really become a problem. And they may not notice social cues. And this is partly related to even some issues that we know about with reading facial expression and kind of responding to that. And these changes to attention can really mimic memory loss. So often I would have people come in and say, oh, his memory's just so bad. Well, when it really came down to it, it was more, if I meet you at a party and you tell me your name, but I'm paying attention to the tray of hors d'oeuvres going by. It's not that my memory was impaired, that I couldn't remember your name. I wasn't paying attention when you told me what your name was. And attention really kind of underlies all of these cognitive domains. And so it can mimic issues in other areas. As I mentioned with executive function, we're talking about planning out a task, following a recipe, following different steps. That can really be an issue. And we know that multitasking, and this is even for people with Parkinson's disease, becomes very problematic. So trying to limit how many things your loved one, or how many things, if you have Lewy, you're paying attention to is very important, because the more things that more balls you're trying to keep in the air, so to speak, that can really cause some issues. We also see a decline in analytical skills. I had a gentleman one time who came in and was having repeated falls, putting on his pants. And so I asked him, have you tried anything differently to correct these falls? Like, have you done anything to see if you could maybe prevent them? And he said, well, I bought bigger pants, but it didn't help. And I remember sitting and trying to think, how would bigger pants help? Well, he had an explanation. He thought that the waistband being smaller and him trying to step into it if it was bigger, that maybe that would be helpful. I don't think that's probably something that he would have thought 5 years previous to that. And they can often present with a lot more difficulty if they're rushed or under pressure. So Time management can become huge. And knowing that with those movement symptoms, their movement can become slower, right? If they have bradykinesia. So it might take them now an hour to get ready to get out the door to go on an appointment to where it only took a half an hour before. So being aware of those things can be really helpful so that you don't set yourself up for failure to where then you're trying to yell at somebody and rush them and then it really falls apart. Visuospatial skills I mentioned, and so sometimes people have trouble seeing the distance between objects. Their sense of direction may be impaired if they're trying to navigate their home or community. And, just the ability to process and respond to visual information can be impacted. Some people can have double vision where they'll see two of something, and it's important to see your eye doctor. There's different types of lenses that you can get. Having a good relationship with your optometrist or ophthalmologist, if you have Lewy, is very, very important. There can even be a loss of color contrast because one of the neurotransmitters involved with this is related to our color vision. Language, as I mentioned, can sometimes be a problem, not as much as with Alzheimer's, but more disorganized speech and conversation. So they'll have trouble kind of keeping train with the conversation. They may have difficulty processing words that have been spoken. So kind of it takes a little longer to process a conversation. And then lastly, as I mentioned, that memory loss may not be really apparent in early Lewy, and it may not show up much at all. So just don't be looking for that. Like I recently was doing an event that was very Parkinson's focused. There were a lot of people with Parkinson's disease, dementia. And I had so many people saying, well, I'm so glad he doesn't have that Lewy thing because he still can remember all our kids and grandkids' names. And it's like, well, that would be Alzheimer's. But they're like, but he does hallucinate. And it's like, that, there we go. Now we're in Parkinson's disease dementia. So I still think this is something that we've all got to try to remove from our concept of dementia, is that it just equals memory problems. All right, so when we're talking about sleep disorders, this can be a lot of different things. It can involve insomnia, where the person has trouble falling asleep or staying asleep, so they're waking up a lot at night. Restless leg syndrome can be part of this, where they feel kind of wiggly or they need to move at night. And I mentioned that REM behavior sleep disorder, where people are acting out their dreams. And, this is a core clinical feature. 76% prevalence is what they estimate. And it can be seen even 15 to 20 years prior to developing other symptoms. So when we talk about movement related, if you're familiar with Parkinson's, a lot of these will really stick out. So anytime you see the word Brady, that just means slow, right? So bradykinesia is slow movement, and their spontaneous movements, initiating movement, a lot of times is difficult. So you might see freezing of gait, where people's feet look like they're stuck and they have a hard time getting started when they're moving. Rigidity just means like stiffness or inflexibility in the muscles. And a lot of times it's around like the elbow flexors, the knees, things like that. So the person's elbows may be flexed, shoulders maybe kind of look stiff, knees look stiff. I mentioned the difficulty with balance and those repeated falls earlier. We often see kind of a slow shuffling manner of walking, where the feet barely clear the floor, and that's where a lot of tripping can happen. So having throw rugs up in the home, having paths clear becomes very important. You may see some quick or kind of jerky movements with the muscle, which are called myoclonus. Tremor can happen, but not always. Even a lot of my people with Parkinson's didn't have tremor. And a rest tremor is if someone's hands resting in their lap or resting somewhere, not doing anything. You'll sometimes see what we call a pill rolling tremor, where the hand looks like you're rolling a pill. But they can also happen in action, where the person reaches for something and the hand starts to shake. And then another one to be aware of is, your face is just like a big mask of muscles. So anything that changes your movement is going to potentially change the movement of the muscles in your face. So we see this decrease in this change in their facial expression, which is typically called hypomania. So they'll look really flat, really non-expressive. This can sometimes be confusing to family members. They feel like the person doesn't look at them with the same, love or expression or happiness or joy. A lot of times children and grandchildren can be very tuned into this because we don't realize how much we look at someone's face for that expression. I realized at one time when I was talking to someone with a whole lot of Botox that had no facial expression, and I remember being so confused because I couldn't read what she was thinking when I was talking. All right, so then when we talk about autonomic symptoms, like I said, these are those things that the body kind of does automatically, right? And these start to be impacted. Loss of smell can happen many years prior, even to other symptoms coming on. They can have issues with temperature regulation where they feel really hot or really cold suddenly, have a lot of sweating and things like that. Blood pressure can really be an issue. And what we see a lot is what's called orthostatic hypotension. So someone sits up or stands up, so they change positions and the blood pressure drops suddenly. And if that happens, the person can actually faint or go unconscious. So it's something to be aware of if you see your loved one stand up or they sit up and they describe feeling dizzy or woozy, probably want to be talking about that blood pressure issue with the doctor because there's medications they can do, different types of pressure stockings, little movement preps to kind of get the blood flowing again. Constipation can really be an issue prior to diagnosis and even after. So looking at, nutrition and getting plenty of fiber and water and exercise. Urinary incontinence can become a real problem. And so voiding schedules or, making sure that you're aware kind of different incontinence products that are out there can be very helpful. We often see drooling and swallowing problems too. So seeing those speech language pathologists to make sure that we're working on that healthy swallow. And then sometimes they can do treatments for drooling. There's different drops or Botox or different things they can do to help with the drooling. This one's so odd, but so linked, a runny nose. And not just runny, people have had this just drippy, like liquid, almost like they look like they have an allergy or cold coming on. I mentioned that dizziness and lightheadedness, and that's not always related even to the blood pressure issues. Sometimes people will really feel a little, almost like a vertigo. And I mentioned that abnormal sweating as well. So now we'll get into the one that's probably the most problematic, I would think, and this is the big bucket of symptoms that is hard for families to cope with, hard as far as managing medically and safely. So these are these psychiatric or behavioral disturbances. And so we'll talk more about what these are. Apathy is really like a loss of interest. So sometimes they don't show much interest in doing anything or getting out. Now, could that be part of depression? Sure. But it could also just be a standalone. Hallucinations, very common. We'll talk about that. Delusions, illusions. And the difference in those is an illusion is where there's a, coat on the coat hanger and it looks like a monster, where a hallucination is you see the monster walking around and it's having a conversation with you or interacting. That's the difference. And then those delusions, we'll get into more of those fixed false beliefs. So when we talk about hallucinations, they can be very vague instead of more exact. The number one that people describe the most is what's called a sense of presence. And there's a really amazing article by a doctor now from Mayo. He was a neurologist who's now has been diagnosed with Lewy body dementia, called Twilight in Me, a soliloquy. And his name is Dr. Daniel Drubosh. And he describes this sense of presence so eloquently in that article. This feeling that something or someone is over your shoulder. And they'll feel like it, just as they turn to try to see, it's like it disappears. And I think how creepy that would feel, or how probably disturbing and bothersome that would be. Sometimes they feel the presence of a deceased relative or a pet. So sometimes this can be good in a way. Like I know one of my former clients now, she sees her deceased husband standing on her right side at all times, and she talks with him and interacts. It's not disturbing or upsetting to her. It sure was to the family for a while. It kind of spooked them a bit until they understood that this is just really a very normal part of this condition. Often they describe seeing something pass in their peripheral vision, and it might just be a shape of someone or a shadow. I talked about that illusion, that misperception of something that is actually there. That can be a problem as well. And that's kind of a trick of the eyes in a way too, and then the brain having that trouble processing that image. So the complex hallucinations, get a little bit more complex. So they can involve sound and hearing or smell or taste or even, sensations or feelings like they're being poked or touched in some way. The thing to know about the hallucinations too is that they can occur very early in the disease. Often it's one of the first symptoms people describe. Seeing a raccoon running up the wall of their living room, things like this that they know are not happening. And it may not be frightening to those who are diagnosed. This is one to really be aware of. My friend recently who has Parkinson's disease dementia, he was having a lot of hallucinations. It was very troubling to his care partner. His care partner was really upset about this. He wasn't really too concerned. So something to know that you may have a different response as a care partner and the person experiencing it. Like I said, typically they're rather benign, people, children, small animals, but they sometimes can be scary, spiders or insects or things like that. And we talk about delusions. This is a false fixed belief. So it's something that the person maintains despite evidence to the contrary, that it's not true. And we see several types in Lewy body dementia, and they mostly are around paranoia. So it's one thing to know that if your loved one starts to become very paranoid, they think that you're cheating on them. Or another one's called phantom boarder. They'll think that there's a person living in the house or living in the couch that's not actually there. And these can be very upsetting, as you can imagine. Misidentification is common as well, where you might think Capgras delusion is one where people will think that their loved one is an imposter, that they've been replaced by, this fill-in person or this imposter person. And then also people may perceive abandonment, that they've been abandoned by their family or their loved ones. So once again, very important to know that these are not just the person being difficult or bad or hard. These are actually happening in the brain. Their brain is giving them all of this false information. And so these can be very difficult to live with and deal with for sure. But please realize that it's not intentional. It's all just Lewy. And then this one, I want to be sure that I make everyone aware of these medication sensitivities, because these can be so impacting. I mentioned that really big one earlier, that Haldol, that people can get this neuroleptic malignant syndrome if they're given Haldol that can be fatal. And typically when you're going to be given Haldol is, let's say your loved one has a fall at home, right? And they've gotten hurt and now you're going to the emergency room. Well, now they're having hallucinations or delusions and they're getting agitated. That's typically when they're going to try to give your loved one Haldol, is to try to calm them and control that behavior. And that's where you've got to know Haldol. We have a medical alert card that you can reach out to us and get that has these warnings in it. We're redoing it to even make the warning more bold. But, if you remember nothing, please know Haldol. It's important to note that some over-the-counter medications can also cause complications. So some of them block other neurotransmitters in the brain. So like diphenhydramine, which is in Benadryl. Some of those medications can be a problem. So you want to discuss all of those with your doctor. Important to note too, there can be kind of a double effect from some of the medications that are typically used. So carbidopa-levodopa or Sinemet is a dopamine replacement therapy for people with Parkinson's disease. And it's the gold standard for treating those motor changes or movement symptoms that we talked about. But it has a potential risk for the side effect of hallucinations. So if someone's had Parkinson's disease, right, and they're starting to transition more into maybe Parkinson's disease dementia, these medications can start to be problematic. Or your person has Lewy and they give them this to help with their movement symptoms. They've got to really look at the dose. Important too, these medications are so sensitive and so precise. You don't want to notice a reaction and just take your loved one off of it. Sometimes you have to titrate or kind of reduce the dose very gradually to wean off of it. So anytime you're having a problem with a medication, reach out to your doctor and make sure you know the plan as far as, introducing another medication or weaning them off of that one. Antipsychotics, like I mentioned with Haldol, but even some of the things outside of Haldol that we use to treat, confusion or hallucinations can be problematic. And a lot of times the dosing has to be very low. They call it low and slow. So you start low and you increase very slowly. So the current treatment strategy then, when we take all of this into account, is really just to improve quality of life. Just like with Alzheimer's and other diseases, a lot of the symptoms can be managed or reduced with medications and with other types of therapies, but there's no treatment currently available to stop or slow the progression of Lewy body dementia. But there is research being done, so we're hoping that there's going to be help on the horizon. And it does take a village. If you think about all of those symptom families I just went through, we really need a lot of cooks in the kitchen here. So you notice I put OT first and foremost. We really help to support independence, promote safety and quality of life. Those physical therapists are really going to help with mobility, preventing those falls and keeping you safe and keeping the person active, which is so important. Speech therapy, they're going to work to really facilitate communication and also safety with swallowing. Social workers, shout out to my social workers in the audience. I keep you on speed dial at all times. They're like the MacGyver to give you all the resources and find support and access to things that you need. And then counseling. As you can imagine, a lot of these changes to mood, to behavior, maybe your loved one thinks you're cheating on them. We really need coping strategies in place, not just for the person with Lewy, but also the family or care partners or whoever is helping out. So I just wanted to show here too, this is one of our experts who wrote a great study, and it's important to know that we don't have any formal studies evaluating therapy in DLB because so often dementia is an exclusion criteria. Resources to assist function, shower not familiar with what the different therapies can do. And so, focusing on physical activities that are enjoyable, maintaining current abilities while we're really preventing the rate of further decline, working on that flexibility to prevent contractures when somebody has those rigid muscles, working on a specific activity like getting out of a chair or getting out of a bed, which really helps decrease the impact on the care partner too. If you're doing less for them, then you're hopefully doing more for yourself. Teaching some pressure relief strategies if that person is seated a lot or in a bed a lot. And then often they're going to assess for the appropriate assistive device. And I can't stress this enough. You don't want to just stick a cane in the hand of someone with LBD, because using a cane involves coordination, it involves your vision, it involves so many things that a lot of times I just end up carrying it and kind of wagging it around. So the type of assistive device, a physical therapist needs to look at what type of walker is appropriate, what's going to be the best way, and train you in using it, not just send you out the door with it. All right, so let's talk about the benefits of OT really quickly, and I'll get to questions. So we really help to improve overall activities of daily living. And you'll notice this was a study here that this was a systematic review, and they really looked at how much benefit people got from OT. What they found when they compared these different groups is that people in the OT group, people with dementia who were getting OT, had fewer behavioral and psychological symptoms compared with these control groups. OT resulted in a better quality of life for people with dementia. Care partners reported fewer hours doing things for the person because we helped to get them more independent. Care partners also reported less distress or upset when their loved one was in that OT group. And then they also saw not only improvement in quality of life for the individual with dementia, but also for the care partner's quality of life. So it's really a win-win. We help to strengthen the whole team. So looking at speech language pathologists, they're really going to screen and help identify these kind of cognitive communication difficulties and give you some strategies to work on them. It's important to note they're not going to try to make you talk like someone else if you have an accent. So their assessments are always culturally sensitive and linguistically relevant so that they are looking at your communication in the scope of who you are. And they can really look to assess and diagnose and treat swallowing disorders. And this is very commonly a problem in Lewy and with Parkinson's that can cause aspiration pneumonia and some very serious conditions. They really work to counsel you and your family on these communication issues and help you understand ways to work around it. And then they're going to look at what is the highest level of your functional ability, throughout the underlying condition to really help that person maintain their function as long and as optimally as possible. And then they may do some indirect intervention in your environment too, and kind of look at ways to modify things in your home to help with those communication issues. So it's important to note that you want to really focus on when you're going into therapy or when you're trying to go, what's my approach? What am I trying to do here? We're really looking at preserving those strengths, not looking at what's lost or what's changed, but what are your strengths? So somebody might not be able to put their shirt on completely by themselves, but maybe if you lay the shirt in their lap, they can put it on. Well, that would be with a little bit of an accommodation, or maybe they need you to just start one arm in and then they can do it. That's less assistance than actually doing the entire task for the individual. So we're trying to find what is their optimal functional level and how can we get them doing as much as possible. So I wanted to kind of leave with this quote here before I talk about some of the resources at LBDA. And this is a gentleman living with LBD who's one of our volunteers at LBDA. And he says, people who've been given this diagnosis can still contribute, learn, and live a meaningful life. And after we talk about all these devastating symptoms, I want to make sure you know that. They also still have a voice, even if they can't communicate the way they maybe did before. So please remember that dementia is a disease. It's not a personality trait. And I think that's so important as we're navigating some of these symptoms that really can be very challenging and confusing. So some take-home points, and then I'm going to tell about the resources at LBDA a little bit. Remembering that Lewy body dementia includes those two types of dementia, Parkinson's disease dementia and dementia with Lewy bodies. LBD is unique and it's different from other types of dementia. It's complex, so you really want to establish a care team to help you with all of the different symptoms. You want to access support and resources all along your journey because your needs are going to change over time. And it's important to stay engaged, maintain physical activities, mental activities, while being mindful of safety too. Okay. So some things just to kind of let you know at LBDA where you can reach out to us. We have a lot of publications for the community and for professionals. You can download these at lbda.org, or from our website, you can order printed copies to be shipped anywhere in the US. You can even order additional copies for your office or for your practice. We really are working to drive awareness. If you haven't seen a little film about Robin Williams and his battle with Lewy body dementia, we have it available to view for free anytime on mediflix.com. And we have supporting resources at the Lewy Body Dementia Association if you would like to do some type of a community education event or even an event for professionals. We feature this film a lot of times with some wraparound content to really help with that. Also available on our Mediflix channel, there's a great video called Understanding LBD with Dr. Jory Fleischer. And so if you have family members that maybe are having a hard time catching on to this and picking up what you're throwing down, you can share that video with them and they can go on and watch it and hopefully gain a better understanding. We also have our Lewy briefs, which are these little video vignettes of different experts talking about Capgras delusion or brain donation, different things that our community has asked for resources to accompany. Important to know, we're only one webinar deep in our community webinar series, so you definitely still have time to join us. We've got an amazing doctor that's going to be discussing disease-modifying trials. Dr. Samantha Holden and her team at the University of Colorado are going to do a 2-hour webinar on vision changes in Lewy. And my dear colleague, Heather Cianci, who's a physical therapist, is going to talk about the movement changes in falls prevention. You can go onto our website and go to our calendar of events to find the registration links for different webinars. Not all of these are up yet, so have a little patience. All right, and then for my clinicians out there, if we have any PTs, OTs, speech language pathologists in the crowd, 4.5-hour masterclass for allied health professionals on the role of PT, OT, academic health centers in the US that have clinical expertise and are ready to do a clinical trial. So these are places that you can get access to high quality clinical care. You can establish a clinical trials ready network. You can get access to the support that you need through support groups or social workers in those centers. You can increase knowledge of Lewy body dementia among medical professionals at a lot of the grand rounds or different conferences that they host. And then these really help us create infrastructure and resources to ultimately advance research in Lewy body dementia. If you are interested in research out there, you can go on our website and under our research tab, find our Lewy trial tracker. And that's a place where you can take a confidential survey and get information about upcoming studies on Lewy body dementia. You are not signing up for a study, you are just signing up that you want information. It's going to give you access to all different types of studies, not just drug studies. You can sign up for yourself or for someone you're caring for. And any researchers in the audience, you can contact us if you'd like your study to be included. And then you'll be signed up at that point to get a quarterly email about studies that are available in the United States. If you don't remember anything else I said today, take this number down. This is our Lewy line, 800-539-9767, or you can email support@lbda.org. The phone is manned, or the calls will be answered by this lovely lady, Brandy Hackett, down in the bottom corner, who is a lovely social worker and our senior manager of support services, or Tori Ricci, another social worker who's in that department as well. They both man our Facebook support groups and also make sure that they vet and train people to do our virtual and community-based support groups. Are you interested in volunteering? You can get involved to do community fundraisers, community event support. You can be a Facebook moderator. You can work on special projects. And so for more information, you go to www.lbda.org/volunteer, or you can email lendahand@lbda.org. With that, I will take questions. I thank you all so much, to each and everyone here, taking your time to come and learn about Lewy body dementia. Definitely warms my heart. So thank you all so much.
Thank you, Julia. That was a fantastic presentation. A lot of great takeaways, a lot of insight into what can be a really mysterious diagnosis. So thank you for that. I love the quote, dementia is a disease and not a personality trait. Love looking at it in that way. So thank you for that. We have some great questions in the chat. So first question is it possible for young people to have Lewy body dementia?
Yes. And I'm not sure how young you mean. I mean, I haven't seen, like pediatric or anything, but we definitely are seeing people, young adults for sure. I know I've heard of people in their 30s and even late 20s. It's not common for sure, but it definitely is a possibility.
Awesome. Thank you. And also anybody asking for a copy of this, I will be sending out a recording. So you'll be able to access all the slides and everything that way as well. Next question is, can you speak more about your comment that a nursing facility is not always the best placement for folks with Lewy body dementia?
Yeah, I think on this one, you really have to do your homework with the type of facility that you're looking at. and make sure that, I mean, questions I think you can ask are, do they have any residents with Lewy body dementia? How familiar are they with Lewy body dementia? A quiz question I would ask is, what medication should you never give my loved one if I put them here with Lewy body dementia? A resource I will tell you to check out is the Parkinson's Foundation actually has expanded their centers of excellence to have what's called a global care network. And so they're going to be certifying different long-term care facilities, nursing homes, things like this, as people who are aware of these conditions and know them well. So I think that there's going to be more resources coming out. But for now, I think you just really have to kind of do your homework, because what can happen, unfortunately, is you also want to ask them, how do they deal with behavioral disturbances and psychiatric disturbances? Because it's almost inevitable that that's going to happen. And we've had people kicked out of nursing facilities over this. So you can always call our Lewy line and talk to Brandy Hackett. Sometimes they know places that, you know, we have people out, or they've taken people, or people having a good relationship with, but it definitely, they're not all the same. I think that we all have to do our due diligence no matter what. You wouldn't want to stick your loved one in any just old place, but I think definitely asking some of those hard questions and sitting down and really interviewing them to see if it's the right place.
Absolutely. Thank you. That's really helpful to keep in mind. Next question we have is, what kind of caregiver support do you recommend for those that do want to care for their loved one at home or in the community?
Yeah, I would say it's really hard to do that fully alone. I think that having some type of a paid caregiver, you know, a home health aide who can come in some, maybe it's even a family member or friend or loved one but you're going to need some support, I would say. And, you know, you just want to make sure if you're getting that support for respite or whatever it is, that once again, they really understand the condition. They know how to work with your loved one. They're going to understand what's going on. But I think it's very hard. And I'm going to say no one ever does it. We do get some care partners that really, you know, tough it out and they want to take care of their loved one, and they do it. But I think a lot of times it's really, really difficult. So if you can't afford paid help, or, you know, if you can have some family or friends come in, I think that's really helpful.
Thank you, Julia. And that is all the questions we have. This was just such a fantastic presentation. I can't go on enough about it. We have a lot of wonderful comments in the chat as well. So I'm going to save those for you and I'll send those to you. And again, everybody keep an eye out for the follow-up email that will have a link to the recording and that survey. And Julia, thank you so much for your time. Appreciate you so much.
Oh, thank you all. Thanks everybody for joining.
Thank y'all so much. We'll see y'all next time.
Bye.